Good morning, ladies and gentlemen. I'm Dr. Mark Warner, President of the Anesthesia Patient Safety Foundation. Thank you for joining us today for the Ellison C. Pierce Jr. Memorial Anesthesia Patient Safety Lecture. Today's lecture is given in honor of Dr. Pierce by Matthew B. Weinger, MD, from Vanderbilt University School of Medicine. His talk today is entitled, "Is Safety Becoming the Poor Stepchild of Quality?" The Anesthesia Patient Safety Foundation has a unique vision that we can all share, that no one shall be harmed by anesthesia care. The Anesthesia Patient Safety Foundation is a foundation of the American Society of Anesthesiologists. It has a board of directors that includes multiple stakeholders from industry, professional societies, the public, and regulatory agencies. One of the key missions of the APSF is to communicate and educate with healthcare providers around the world. The most common way we do that is through the APSF newsletter and through our website. The APSF newsletter has had more than 1.6 million website page views throughout the world this past year. The newsletter is published in 6 languages and has readers from every country in the world. Patient safety research grants and career development awards are also part of our mission. Our goal is to develop the next generation of patient safety scientists in anesthesiology. We've given $13.5 million over a 30-year period to support research grants, particularly for early career scientists, clinicians. We have investigator-initiated proposals, and we also have targeted projects. We annually prioritize patient safety initiatives, and then we target those through supportive research and through our educational efforts. Ellison C. Pierce Jr., MD, is an incredible individual and one of the most influential physicians and anesthesiologists of the past century. In honor of his vision and unwavering commitment to patient safety, we have found that the Pierce Memorial Lecture allows us to extend his vision for improving patient safety in anesthesiology. Dr. Pierce is the past president of the ASA, the founding president of the APSF, and in the past century was extraordinarily influential amongst patient safety advocates. Dr. Matt Weinger will be giving the lecture today. He is a driving force in anesthesia patient safety. He has a remarkable academic record. He's the Norman Ty Smith Chair in Patient Safety and Medical Simulation at Vanderbilt University. He established the use of scientific, human factors, and engineering principles to create new safety methodologies. He's a huge advocate for career development of patient safety scientists and career investigators in patient safety. And he personally has had more than $12 million of extramural patient safety research funding in over 50 federal and foundation grants. So he's humbled, but honored to give this talk. He's also honored in many other ways. He's one of the most highly honored anesthesiologists in patient safety. He's won the J.S. Gravenstein Award from Society for Technology and Anesthesia, the Loftman Great Batch Award from the Association for the Advancement of Medical Instrumentation, designation as a Fellow of Human Factors and Ergonomics Society. He's the only physician to ever receive this honor, and the James S. Todd Memorial Award for Patient Safety from the National Patient Safety Foundation. We're indeed pleased and honored to have Dr. Weinger give this presentation, "Is Safety Becoming the Poor Stepchild of Quality?" Thank you, Dr. Weinger.
Thank you, Dr. Warner, for your kind introduction. and thank you to the American Society of Anesthesiologists and to the Anesthesia Patient Safety Foundation for this great honor. First, I have two disclosures. Neither are relevant to this presentation. Jeep Pierce is in the middle of this 1986 photo of the members of the original APSF Board of Directors. I had the pleasure of knowing Dr. Pierce, although we never really worked closely together. The youngest member of the board, Jeff Cooper, is on the left side. This quote from Jeep is at the core of what I will discuss today. It remains as true today as it was decades ago when he said it. Patient safety is not a fad. It's not a preoccupation of the past. It's an ongoing necessity. It must be sustained by research, training, and daily application in the workplace. Here's what I'm going to talk about today. We'll start by reviewing why we as anesthesiologists should care about safety. We'll next explore briefly an important and underappreciated consequence of unsafe work environments: the impact of dysfunctional systems on the safety and well-being of clinicians. Then we'll talk about the need for greater healthcare quality in this country. We'll discuss when and why safety and quality can conflict. And finally, we'll talk about a way to design safer systems. A brief musical interlude will indicate transitions between these sections. The music was performed by my friend and colleague, Dr. Joseph Schlesinger. Let's start with the usual statistics. Most of us remember the numbers provided in the 1999 Institute of Medicine report To Err is Human. 44,000 to 100,000 patients die each year due to medical errors. The report goes on to state that about 1/2 of these deaths are in surgical patients, and about 1/2 of the medical errors appear to be preventable. While subsequent studies have questioned these numbers, some claiming more, others claiming fewer care-related preventable deaths, I think we can all agree that they're still far too common. Purely anesthesia-related deaths are even less common and depend substantially on patient comorbidities. Because serious anesthesia harm events are quite rare, it is more difficult to come up with exact numbers. But based on my review of the literature, I'd estimate anesthesia-related mortality today to range from about 1.25 million in ASA1 patients to perhaps 1 in 2,000 in sicker ASA3 to ASA4 patients. Now contrast this with all-cause 30-day surgical mortality, which appears to be in the range of 1 to 1.5%, which is perhaps 100-fold more common than anesthesia-related mortality. Further, so far we've only talked about deaths. Many more patients have permanent morbidity, organ damage or nerve injury associated with perioperative care. And again, retrospective analysis of these events generally find at least half of them to be potentially preventable. I'd now like you to consider how much anesthesiologists can influence preventable surgical morbidity and mortality. It's likely appreciably more than many of us have previously considered. Just a few examples. More reliable timeouts can prevent wrong patient, wrong site, or wrong site surgery. Appropriate and timely antibiotic and DVT prophylaxis will prevent these types of complications. Better intravenous and drug administration sterile technique by anesthesia providers will reduce surgical infections. I refer you to the eye-opening research of Randy Loftus and David Birnbach. And optimizing hemodynamic management during surgical misadventures will decrease postoperative organ dysfunction. In summary, anesthesiologists are in a unique position to prevent perioperative events and improve patient outcomes. Let's explore the nature of events during patient care. About 20 years ago, I introduced to healthcare the concept of a non-routine event, which I borrowed from the nuclear industry. In a nuclear power plant, there are standard operating procedures, or SOPs, for nearly every possible situation. Most of the time, work in nuclear power is routine. However, when a deviation from an SOP occurs, it's viewed as important information about system performance and is analyzed thoroughly. In healthcare, we rarely have SOPs, in part because patients and their presentation are so variable. Instead, for a given patient presenting, say, to the operating room for a specific procedure, we have a pretty good idea beforehand what that patient's optimal care path and optimal outcome should be. So, a terminally ill cancer patient having a palliative procedure, she's not going to be completely healthy afterwards, but we certainly don't want to cause her any harm that could diminish her quality or length of life. On a given day, there are many factors within the healthcare system that could affect the ability of the team to care for that patient. Their surgeon could be sleep deprived, their anesthesiologist could be stressed or distracted, the hospital might have a drugs or supply shortage. These are called performance shaping factors, and they influence the nature and consequences of non-routine events, or NREs, that might occur. We define a non-routine event as anything that's undesirable, unusual, or surprising for a particular patient in their specific clinical situation. When one or more NREs occur, this increases the chance of a deviation in that patient's care path. Especially for serious NREs, if the event isn't recognized and the patient rescued, there's an increased risk of adverse outcomes. In contrast, if that care path deviation is recognized and addressed, there's recovery back to the expected path and outcome. My colleagues and I have been studying non-routine events in healthcare for almost 20 years. In one of our first studies, we interviewed anesthesia residents and nurse anesthetists in the recovery room after randomly selected non-cardiac cases using a special tool designed to elicit NRE reports. We also video recorded each of these cases. In more than 30% of these anesthetics, at least one NRE was reported, and in almost a quarter of the NRE containing cases, there was some kind of temporary or potentially permanent physical or psychological injury. In a follow-up study at a different academic medical center using similar methods, which was published in July in the journal Anesthesiology, we found a somewhat lower but still substantial incidence of anesthesia-related NREs and associated injury. NREs do not just occur in the operating room. In an observational study of ICU nurses, 35% reported at least one medication-related NRE after 4 hours of observation during either a day or night shift. Several patients had injury events. NREs unrelated to medications were not captured. So these NREs occur pretty frequently. Admittedly, many are minor and of little consequence to that patient, but they do tell us about the overall robustness of the system and the nature of that system's performance-shaping factors and risk. For example, while a delayed lab result might not have led to harm in the patient case in which that NRE was reported, it provides evidence of potential inefficiencies or issues with perioperative results reporting that could harm a future patient. Based on our NRE studies, work we've done with experienced anesthesiologists managing simulated crisis events, and my review of the literature, I've generated a short list of the common ways the perioperative care system can lead to preventable harm. The most common failure modes are delayed or misdiagnosis, delayed or incorrect treatment, failure to follow best practices, communication failures, failure to escalate care, failure to adapt to changing situations, and technology-related use errors. This provides us guidance as to where we should direct our safety efforts. So, how should we think about safety to best address these preventable events? In the traditional pre-1999 view of patient safety, humans are inherently error-prone, and the best solution is to fix the humans. This is sometimes called the shame, blame, and train approach to patient safety. In a hospital with this view of patient safety, a nurse would be fired for making a medical error that was associated with serious patient harm. After the publication of To Err is Human, American healthcare began to adopt what is called the new view of safety, also called Safety 1.0. In this view, defective processes and systems are the cause of accidents, and the system must be designed to prevent human errors from causing harm. This is the prevailing approach to patient safety by most enlightened clinicians and healthcare organizations today. However, especially after an accident, it's all too easy to slip back into the traditional view. We'll address the reason for this in a little bit. But recognition has been growing that safety improvements that rely primarily on the analysis of accidents or errors will be limited in their effectiveness, in part due to hindsight bias. But more importantly, because this approach doesn't provide sufficient evidence as to how best to prevent future accidents. So increasingly, patient safety professionals are following the lead of other high-risk industries to adopt what is called Safety 2.0. In this approach, everyday, routine, as well as more challenging clinical situations are observed and analyzed to understand how and why clinicians do as well as they do, despite the many failure modes embedded in existing processes and systems. Until recently, commercial aviation has taken a Safety 1.0 approach to accident prevention. In the last 10 years, there have been over 240 million flights, but only 388 crashes, a failure rate of 0.17 in 100,000. This is similar to the incidence of anesthesia-related death in healthy patients. But in data collected by NASA from their aviation safety reporting system, in about 20% of all flights, events occur that could have caused a catastrophe, but the pilots detected the situation and did something to correct it before it went awry. Perhaps not coincidentally, this is similar to the incidence of anesthesia-related non-routine events. NASA has recently launched a Safety 2.0 initiative to study what successful pilots do during events to solve them. We should probably be doing the same thing in healthcare. When talking about safety in healthcare, it's not just about patient safety. We also have to consider the safety of clinicians and of the organization as a whole. When an organization has an undue emphasis on production, has dysfunctional processes and technology that predispose to unsafe care, or has a culture and leaders that don't adequately understand and support frontline clinicians, this can have appreciable adverse effects. Studies show that such poorly designed systems increase the likelihood that clinicians will have job dissatisfaction and be less engaged in their organization, experience burnout, have more occupational injuries, and even this can produce adverse effects on clinician well-being, including an increased risk of depression and suicide. Burnout is defined as a syndrome of emotional exhaustion, cynicism, and a decreased sense of professional worth. Burnout occurs when job demands and work stresses persistently exceed the available resources and resilience of the individual. According to numerous studies, 35 to 50% of all U.S. physicians and 30 to 40% of all U.S. nurses report symptoms of burnout. When thinking about burnout in anesthesia, studies show that anesthesiologists' incidence of burnout tends to be about average, around 50%, compared to other physician specialties. Nurse anesthetists report less burnout compared with anesthesiologists, and also less than ICU nurse practitioners. The prevalence differs across anesthesiology subspecialties. In a paper currently under review, we surveyed a 20 to 40% sample of all members of ASRA, SCA, and SPA using the Maslach Burnout Inventory, the best validated tool for this purpose. We found that burnout symptoms were highest, about 62%, in chronic pain physicians and lowest, about 30%, in pediatric anesthesiologists. The incidence was intermediate in generalist, regionalist, and cardiac anesthesiologists. Many of the factors that have been associated with increased risk of burnout, shown here, happen to be the same performance-shaping factors discussed previously and known to be associated with the risk of non-routine and preventable adverse events. So the bottom line is, work systems that don't support clinicians' needs will degrade both patient and clinician safety, as well as overall organizational performance. For example, in healthcare organizations, a higher proportion of burned out clinicians is associated with decreased care quality, more medical errors, lower patient satisfaction scores, as well as more clinician turnover and higher operating costs. I now want to tell you about Alcoa Aluminum. When Paul O'Neill started as the CEO in 1987, Alcoa had lagging performance and a truly dismal safety record, averaging 1 accident in every plant each week. In his first speech to investors, O'Neill stated, "I intend to make Alcoa the safest company in America. I intend to go for 0 injuries." Most people, particularly investors, thought he was crazy. O'Neill, on the other hand, thought that the company and its employees needed an intense focus on improving process to make the company more efficient and lower cost. But O'Neill knew that employees would be unable to understand, much less be motivated by, quote, streamlining production processes. In contrast, O'Neill saw worker safety as something that could win to his employees' hearts and minds. Plus, you can't improve safety without deeply understanding work processes. 13 years later, when O'Neill left the company, Alcoa's injury rate was 1/20th the average of all US companies. And that's not just manufacturing companies, all companies. And its income had risen 5-fold. So why focus on safety? Similar to Alcoa, for healthcare, few frontline clinicians are inspired by hospitals' executives' exhortations to improve throughput or to increase return on investment. Saving lives and preventing injuries is inspiring to clinicians and well aligned with their values and motivations. Further, a focus on worker well-being gives workers a reason to believe in the organization. Inspired and motivated workers deliver better performance. And studies show that the highest functioning hospitals have the highest levels of clinician engagement. But when is safe enough? While we should always strive to be safer, it's impossible to be perfect given the complexity of humans and of modern healthcare. To make healthcare safer is going to require appreciable effort and resources. Yet we must recognize that making care much safer will conflict with other societal and organizational priorities. The greater the demand for clinical services, the fewer resources will be available for increased staffing, safer technology, and process reengineering necessary to improve safety. Second, as we'll discuss in the next section, the US healthcare system has a serious quality crisis that must be addressed. Third, America already spends a massive amount on healthcare, and it's going to be challenging to convince healthcare leaders to invest any increased resources to improve safety. And why are quality and cost dominant factors in the attempts to re-engineer the American healthcare system? Healthcare in the United States, when compared with other developed countries, is generally of lower quality, is less safe, and has a higher proportion of total expenditures going towards activities that don't directly benefit patients, including billing, administrative costs, and profit. The US healthcare industry is a $3.5 trillion industry. We spend more on healthcare than the gross domestic product, or GDP, of all but 4 other countries in the world, just on healthcare. Further, most of the health and healthcare dollars in this country go towards treating disease rather than promoting health or preventing disease. I'll provide additional evidence to support these claims in the next few slides. Since 1980, the U.S. has spent more dollars every year on healthcare as a percentage of our GDP than any other high-income country. Using internationally accepted measures of healthcare system performance, such as infant and maternal mortality and effective management of chronic diseases, the U.S. has lower performance than other high-income countries while spending appreciably more per capita. Each year, U.S. hospitals and clinicians spend about $500 billion on billing and insurance-related costs, about twice as much as necessary, according to a 2010 National Academy of Medicine report. And in a 2017 study by Wohlhandler and Himmelstein, published in the Annals of Internal Medicine, the total cost of administration of the U.S. healthcare system was estimated at $1.1 trillion, about 1/3 of the total cost, and little of which directly improves care quality. Life expectancy in the U.S. isn't only lower than in all other developed countries. We're also the only one in which life expectancy has actually decreased over the last decade. Finally, there's a mismatch in how we spend our healthcare dollars. Numerous studies suggest that at least 40% of the factors that cause medical disease, morbidity, and mortality are related to unhealthy behaviors such as smoking, alcohol, overeating, and inactivity, and more than 20% is due to socioeconomic and environmental factors. In contrast, only 20% is related to genetics, and just 6% is due to inadequate access to health care. Yet, the vast majority of America's healthcare expenditures are on the delivery of medical services to those who are already sick, and less than 10% of expenditures are for health promotion or disease prevention. As you can now see, there are ample reasons to want to increase healthcare quality in the United States. With escalating costs and poor outcomes, there's increasing societal and organizational emphasis on improving value. In this context, value is defined as the quality of care obtained divided by the cost of delivering that care. And because cost is in the denominator in the value equation, the effectiveness and efficiency of care have become a predominant focus in most organizations' quality initiatives. As we'll show in the next two slides, hospitals that adopt a production-oriented approach to quality improvement may put patient safety at risk. Most manufacturing organizations are production or value-oriented, focusing their improvement efforts on efficiency and cost reduction. In contrast, high reliability organizations such as aircraft carriers and nuclear power plants focus on safety and have a substantial and strong safety culture. Let's explore how these two types of organizations may differ. A production focus emphasizes optimization, wanting to have just the right amount of personnel, tools, and supplies available just when they are needed. In contrast, safety or high reliability organizations want built-in redundancy and take a just-in-case mentality. As in a manufacturing line with a production focus, increased standardization is a key objective. The safety organization accepts some diversity of practice to have maximal options for addressing unusual events and situations. Once optimized, the production orientation tends to resist change, while the safety organization embraces and explores opportunities for change and for safety improvement. The production organization treats adverse events as anomalies to be avoided, while the safety organization views adverse events as valuable information about how the system may be improved. The production organization tends to be optimistic about outcomes, while the safety organization is pessimistic, always looking for ways to improve. The production organization tends to have a shame and blame culture, whereas in the safety organization, those who report errors or issues are praised and even rewarded. Thus, with a production orientation, the system is more error-prone. In contrast, in a safety organization, it is error-tolerant and, more importantly, will be resistant to serious accidents through better error detection and recovery. I ask you, which type of organization is your hospital? I'll now explain how the production orientation will increase the risk of safety problems in the operating room. Imagine the business of running the operating room represented by this triangle depicted on a safety gradient from green in the lower right, safest, to red, least safe. The three boundaries of this triangle are productivity. In the OR, this is sometimes called throughput, the financial cost of delivering that care, and the safety boundary beyond which the risk of harm events occurring becomes unacceptable. Productivity and cost are easily measured, whereas safety, while real, is less easily measured. Serious adverse events are rare, although when they occur, they are costly for everyone. We only know we are in unsafe territory when bad things happen. Imagine our operating rooms were functioning at the green dot. There will be intense organizational pressure to increase productivity, to do more cases per OR per day, and to lower the cost of delivering that care. This would move the green dot up and to the left. Now we would be operating much closer to the OR safety boundary. Some staff will notice and warn the organization of the risk, but because of the competing pressures and the fact that nothing bad has yet happened, the situation would be perceived by many in the organization as still being safe. In fact, some in the organization will argue that the safety boundary is actually further out. In other industries, this is called drift towards failure. Once there is normalization of the deceptively expanded safety boundary, there'll be renewed pressures to increase productivity and lower cost. Usually by this point, there's recognition in the organization that we're pushing the safety envelope or boundary. But in the absence of serious events, there's often a belief that nothing bad's going to happen. In fact, the risk is high that a preventable catastrophic event will indeed occur. So, to give safety a stronger negotiating position in day-to-day operations, we need a reliable safety meter in the operational environment. This tool would allow us to tell when productivity and cost pressures are eroding our safety margin and increasing the risk of adverse events. Unfortunately, the technology shown here does not yet exist, and instead today, the only safety meter is you. Your willingness to speak up, to stop the line when you see something dangerous, and to advocate for patient and clinician safety. How can we better design processes, technology, and systems to achieve the level of safety and quality that this nation deserves? In this last section, I'll introduce you to relevant concepts in human factors engineering and human-centered design. Human factors engineering is fundamentally a human-oriented endeavor that focuses on design. It's the scientific and practical discipline of understanding and improving systems, which consist of people, processes, and technology, in order to increase overall system safety, effectiveness, efficiency, and the satisfaction of the people who work in that system. A key concept in human factors engineering is that to get optimal results, tools, technology, and processes must be designed based on actual human needs and capabilities. Human factors engineering has been successfully used across many domains and with appreciable success. For those who are new to this topic, I recommend the now quite old but still excellent introductory book by Donald Norman called The Design of Everyday Things. Let me show you a couple of short video clips from actual anesthesia cases to demonstrate events that are technology or process design failures. These are from our non-routine event studies mentioned earlier and described in a recently published paper in Anesthesiology. All of the clinicians and patients in these videos gave us permission to use them in educational presentations. This first video shows the failure of an operating room bed as the patient is being intubated.
Right there, the bed's not locked. Somebody stand at the end of the bed. Because I'm leaning on it. It has to be locked because I've already changed the height of it.
This next video shows a distraction from the failure of the electronic health record to capture vital signs in the middle of a case. Here the surgeon is doing a fiber optic bronchoscopy while the anesthesia professional is on the phone with the help desk to troubleshoot the EHR problem.
Hey, it's in OR number 10, and it's kind of a new OR. They just revamped it, and my computer, my gas chart is not collecting vitals. Let me just get out a gas chart and turn it off. Turn it off like from the hard drive. Is that for real? Yeah. I'll just get a little fun one. They're ready for double lemon too. Okay. Actually, I have to. Can I call you back in a minute while you're working on that?
When we recognize that there's a safety problem, how do we go about fixing the process, technology, or system? The risk mitigation hierarchy describes the ways an organization can address problems and the overall effectiveness of each method. From most to least effective, the possible strategies are: first, eliminate the flaws through design. We'll talk about how to do this in a little bit. Second, incorporate constraints or forcing functions. An example of this is the technologies that prevent hypoxic flow on anesthesia machines. Third, make errors or failure modes more visible. This is one role for alarms. Next is add warnings. For example, a label on an infusion pump might say, "Caution, clamp IV before removing from pump." Next, one could provide new or more end-user training. One can change labeling, for example, to constrain the intended use labeling to eliminate quote-unquote error-prone groups. For example, quote, "for use by experienced cardiac anesthesiologists only." Or one can accept the risk and live with the consequences, what I call the Ford Pinto strategy. Why are the strategies at the bottom less effective than those at the top? In part because they rely increasingly on individual humans rather than design to exhibit heroic behaviors to prevent bad outcomes. And we know that humans are imperfect and least reliable when they are under stress, time pressure, or distraction, common during adverse events. So if this is true, why are most identified safety risks in organizations addressed, at least initially, with lower efficacy strategies, most commonly warnings, training, and labeling? Because it's less expensive to use those, both in terms of money as well as just effort. I'd now like to introduce the human, or sometimes called user-centered design cycle. This is how human factors engineers design and deploy any new or revised tool, technology, process, or system. The cycle starts with gaining a full understanding of the problem you're trying to address. This user research ends with a definition of users' needs. Next, you specify the use-related design requirements that will drive your design. Then you conduct multiple iterations of design and evaluation cycles as your design moves from concept to high-fidelity prototype. Then, after verifying that you've successfully built what you had specified, you validate the final product by assessing it in realistic conditions to assure that it meets users' needs. The resulting tool or process is then implemented in the clinical environment, and if it needs refinement, the HCD cycle can begin again. This initial user research is driven by key questions about the users and the context of intended use. What are the user's characteristics, such as their age, gender, prior training, or experience? What are their needs? How do they currently meet those needs? What are the relevant characteristics of the environment in which the tool or process will be used? And what's the desired future state, the goals and expectations of end users, as well as of other stakeholders such as managers and maintainers? Now, how do we get this information? User research starts with reviewing the available literature and examining existing processes and products. We observe users in their native environment. We interview users using special techniques and also talk with other stakeholders. Sometimes creating simulated environments or computer models help us test assumptions and potential solutions. And finally, we can conduct formal studies. I now want to describe a research study that generated important information about users' needs. We wanted to understand how a national population of experienced anesthesiologists managed crisis events so we could identify ways we could improve patient outcomes after these rare emergencies. 263 consenting board-certified anesthesiologists who were already participating in MOCA simulation courses at one of 8 American simulation centers were video recorded performing highly standardized simulated emergency events. Here you see the resulting distribution of scores of all the participants as rated by independent, blinded, certified anesthesiologists. Overall medical and technical performance, that is, did they do the right thing clinically, is shown on the x-axis, while their non-technical or behavioral performance, did they do it the right way, is shown on the y-axis. Overall, about a third of the BCAs did quite well, while about a quarter didn't do very well. This study identified a number of specific performance gaps in this population of experienced clinicians, including a failure to speak up, a failure to escalate therapy when standard treatment isn't working, and a failure to follow evidence-based guidelines. In the third step of the human-centered design cycle, you want to iteratively design and evaluate your product or tool. Here I show a sequence of prototypes that we developed for a new display intended for use by ICU nurses. You can see the progression from hand-drawn sketches to a fully interactive prototype. Each version was rigorously tested with formative usability testing in nurses. The purpose of this product was to supplement or replace the trends provided by tables of numbers in the EHR. Instead, we wanted to show a display or graphical object of the trends of vital signs and test results with the goal of better supporting ICU nurses' ability to more rapidly and correctly identify patients who might be getting into trouble. I don't have time to describe the validation study we conducted and published, but this type of display indeed improved nurses' diagnostic performance compared to electronic tabular flow sheets. Instead, as an example for the fourth or validation phase of the cycle, I want to show you a summative usability study we did of 2 commercial products. In this case, hardware and software to double-check blood products prior to their administration. Our hospital had had several wrong blood administration errors, and to address this issue, they decided to explore a technology solution to replace our manual processes. An institutional RFA yielded 2 vendor product finalists that on paper seemed quite promising. The hospital then asked us to evaluate whether, from a human factors perspective, they should purchase either product. We studied 22 clinicians from different disciplines who are likely to do blood transfusion in several different realistic, high-fidelity simulated scenarios in which we embedded errors such as a wrong patient or a wrong blood type. In our studies, clinicians indeed identified all of the errors, but their completion times were longer using the technologies compared with our current manual process. Further, users were frustrated by having to repeat steps and with other hardware and software usability issues. Importantly, the technologies did not support emergency transfusions, the scenario most prone to errors. As a result, the hospital decided to stick with manual double-checking. We provided extensive feedback to both vendors and told them that we'd reconsider their product if they'd fix the issues that we identified. We never heard back from them. Finally, let me describe a study we did to improve the safety and reliability of postoperative handovers in the PACU. We designed a multimodal intervention that centered on 2-hour collaborative training sessions in our simulation center, where ultimately 452 anesthesia professionals and PACU nurses, relieved from regular work duties, trained together to learn a new way of doing handovers. The intervention also included a custom electronic bedside handover tool that reinforced the new approach, as well as formal feedback to individuals as well as to the units on their actual handover performance. We also provided a 1-hour simulation-based refresher course 4 to 6 months after the initial training. Over the course of this 2-year study, independent trained nurses observed and rated almost 1,000 handovers performed by 226 anesthesia professionals and 118 PACU nurses. This figure shows how the quality of actual observed handovers improved over the course of the study in our adult hospital. Baseline performance is shown all the way to the left in the red line, and the color shading in both lines shows the 95% confidence intervals. An institutional team predefined what was to be considered an acceptable handover, and at baseline, less than 20% of the handovers met these institutional criteria. Now, the blue line shows performance in handovers in which at least one of the 2 observed individuals, either the anesthesia professional or the nurse, had received the simulation training. As you follow this blue line over time to the right, you can see a steady increase during training, and then this level of performance, about 60 to 70% of these handovers met the acceptability criteria, was maintained for about a year after completing the initial training. Now let's look back at the red line. This line represents handovers done by anesthesia professionals and PACU nurses who had not received any simulation training. In the second phase of the study, after day 304, almost a year, these clinicians, who were generally those who were new to the organization. Yet this group's performance, despite having not received any training, continued to increase, reaching a level at the end of the study that was indistinguishable from those that had received formal training. This finding supports the occurrence of culture change. The new clinicians learned our new way of doing handovers from those who had already been trained. The custom electronics handover support tool also supported learning of this new process. To demonstrate cultural sustainability, we returned to the PACU 3 years after the initial study had already ended and no further training had occurred to observe handovers. 87% of these observed handovers were scored as acceptable. To support the design of new safety interventions, I'd like to propose an acronym, PopTech, which stands for People, Processes, Technology, Environment, and Culture. PopTech is how human factors engineers think about performance shaping factors, the ones that affect how reliably systems actually work. Unfortunately, today I don't have time to go into greater detail on the elements of PopTech, although we've discussed many of them. We'll save that for future discussions. Let's wrap up by talking about what an organization needs to do to become safety-oriented or high reliability. For a just-in-case approach, the organization needs to create backup systems, to train in teams in serious event management, and to cross-train individuals and teams. Standardization is important for quality as well as for safety, but especially for safety, it must be flexible and open to continual adjustment. Anyone should be able to propose to study the effectiveness of promising new ways of doing things in the organization. Processes and technology must be engineered to be safety-oriented, air-tolerant, and facilitate air recovery. This requires a detailed understanding of how work is actually performed and what frontline clinicians must currently do to make those systems work safely. The organization needs to have robust event reporting systems that encourage and even reward reporting, and then they need to analyze all meaningful events and provide feedback to frontline providers, particularly those who did the reporting. Defective processes and technology need to be redesigned or eliminated. This is multidisciplinary work that requires teamwork and communication, and to do this, the clinicians need to be fully engaged in the organizational efforts. All of this starts with enlightened leaders who actually understand and prioritize safety and who put real effort into creating a robust safety culture. In closing, I want to emphasize that anesthesiologists are not, nor must we simply be, clinicians who put people to sleep. Compared to other clinicians, we have unique training, knowledge, and skills. We were the first specialty to consider and embrace patient safety, and we are still uniquely suited to be the safety leaders in our organizations. We're technology and process savvy, we're systems thinkers, and we love to solve problems. However, to be successful, we need to take a broader view of our role and potential impact in healthcare, and this is especially true to advanced safety. So, as you return to the operating room in the coming days, think about how you can be a safety superhero. Because anesthesiologists, we're where the action is.
Thank you so much, Dr. Weinger, for an outstanding presentation. Ladies and gentlemen, that concludes today's presentation. I would like to offer one final thank you, and that is to each of you. I'd also like to offer an opportunity for you to support our mission that no one shall be harmed by anesthesia care, and make a donation to the APSF in honor of Matthew B. Weinger. You could also consider a donation in your name, a donation in honor of a friend or colleague, a donation that might memorialize a mentor. To learn more about giving, please visit our website as shown on this slide. Thank you and have a very good morning.